Hello all of you. So welcome back to my channel which is Study Smart with me, and this channel is all about the study content in a very specific manner. So first I am beginning it with endocrinology, an important topic related to that, which is diabetes mellitus. So we'll be discussing everything in that related to the pathophysiology of diabetes, what are the basic introduction of diabetes, what are the types, and what is the treatment related to that. So let's begin our video with the pathophysiology of diabetes. Right, so we'll be discussing firstly with the type 1 diabetes mellitus. Okay, so what is this? This is an autoimmune disease. Okay, and what are the antibodies against to that? That is in beta cells of pancreas. So you have to remind these things, and these things can be asked as a MCQ basis, and you have to remind that for the proper introduction related to that for the diabetes. Okay, now we have to remind this that HLA-DR4 is greater than HLA-DR3 in diabetes mellitus. Now what happened, like there are some antibodies detected in patients who will be later going to develop type 1 diabetes, and that is IAA, which is islet associated antigen, this, and there is an GAD antibody, which is glutamic acid decarboxylase. These are detected in patient who will be later going to develop type 1 diabetes mellitus. But what happened, like their prognostic significance is not yet clear. Okay, prognostic significance is not yet clear. Correct? Now what is the thing we have to discuss? What is the diabetes mellitus? A very basic introduction related to that. So what is this? This is the most common condition which is now encountered in a clinical practice. And what is this? This is becoming a significant burden on our health system in the developing world, because most of the people are having this diabetes mellitus nowadays, and it is now estimated that 8% of the total NHS budget is now spent on managing patients with diabetes mellitus. Right, now what we'll be going to discuss, what is diabetes mellitus. This is an chronic condition, okay, which is characterized by abnormally raised level of blood glucose. So what happen in that, guys? In this, there will be an increase of blood glucose. Okay, so this is the chronic condition, and what happened, there will be an increased blood glucose. Now what is the thing, why management of diabetes mellitus is so important? If you think what happened, actually, if I tell you in a very simple manner, what happened if diabetes mellitus will be left untreated, okay, so it can result to death. Also, poorly treated type 1 diabetes mellitus, okay, can lead to significant morbidity and mortality, and that is as a result of diabetic ketoacidosis. This can lead to diabetic ketoacidosis. However, what is the thing is, our main focus of diabetes management is now to reduce the incidence of macrovascular and microvascular complications. So what happened, like this diabetes can lead to other complication too, which could be macrovascular, as if I tell you related to that, that is ischemic heart disease and stroke. Also, if we discuss about the microvascular, this can lead to eye disease, this can lead to kidney damage, this can lead to nerve damage. Okay, this we have to reduce the incident of macrovascular and microvascular complications. You're getting me? Right, everything is written there. I'm highlighting just because you can get it as per what I am telling you, the most things. Okay, and you have to listen carefully. Whatever I'm saying, you will be definitely learning throughout with that only. So let's discuss with our type 1 diabetes mellitus, T1DM. Now this is an autoimmune disorder, correct? And what happened where the insulin producing beta cells of islets of Langerhans in the pancreas are destroyed by the immune system. So what happened in that? In this autoimmune disorder, what happened? This insulin producing beta cells, which is the islet of Langerhans in the pancreas, get destroyed, okay, by the immune system. So what happened? This results in absolute deficiency of insulin, and that can resulting in raised glucose level. So what I want to tell you is there is an deficiency of insulin, okay, which can lead to increase of glucose levels. And what get destroyed over there? Insulin producing beta cells, right? So this is about that. And now patients tend to develop T1DM in childhood, type 1 diabetes in childhood, okay, or early adult life, and typically present unwell and possibly can lead to what? That is diabetic ketoacidosis. Please, wherever you are sitting, just remind it. Whenever I'm repeating it again, you also repeat it again, so you will complete this topic with me itself. Like after completing this video, you don't want to repeat it back again, so do it like that, okay? Now we'll be discussing about the type 2 diabetes mellitus, that is T2DM. And what is this? This is most common cause of diabetes in the developed world. What happened in that? There will be a relative deficiency of insulin, okay, due to an excess of adipose tissue. So what I am telling you is there is like I'm writing it over there, there is insulin deficiency, okay, which can lead to excess of adipose tissue. I'll be writing it there so you don't get messed up. Adipose tissue, okay. So what I am telling you is this relative deficiency of insulin due to an excess of adipose tissue. In simple terms, if we discuss, if we think about it, there is enough insulin. There isn't enough insulin. What happened in our body? If there isn't enough insulin, there will be an excess of fatty tissue, right? And if there is an excess of fatty tissue, what happened? It can lead to blood glucose creeping up. It can lead to increase the level of blood glucose. So like decreasing of insulin, isn't enough insulin, lead to what? Excess fatty tissue. And excess fatty tissue, what can it do? It can lead to increase the level of blood glucose, right? Now we'll be discussing about the pre-diabetes. We'll be discussing pre-diabetes. So this is the term used for the patients who don't yet meet the criteria in the formal diagnosis of type 2 diabetes. Like those patients who are not meeting up the exact criteria to suffer with the type 2 diabetes mellitus, but in a coming years they can tend to develop this disease. So what they need to do, they need to require a closer monitoring and lifestyle interventions such as weight loss. They have to modify their lifestyle ASAP. So what happen, they can just tend to reduce their chances to get the type 2 diabetes mellitus. Mind my words, type 2 diabetes mellitus, okay. Now we are discussing about the gestational diabetes. What is this? This is for the pregnant woman. Like some pregnant women will be developing raised glucose levels during pregnancy, and this is really important to detect, because if it left untreated, it can lead to adverse effects to mother and the baby, right? We'll be discussing everything related to the basic things. Like you have to understand everything from the basics, so you can just remind everything in your mind from the starting to the ending, okay. Now we'll be discussing about the MODI, okay. We'll be discussing MODI, maturity onset diabetes of the young. M for maturity onset diabetes in young. Okay, a group of inherited genetic disorders affecting the production of insulin. There will be some genetic disorders which will be affecting the production of insulin. Okay, and that will be results in younger patients to develop the symptoms similar to those with type 2 diabetes mellitus. Okay, that could be asymptomatic hyperglycemia, and with progression to more severe complication, that is diabetic ketoacidosis. Okay, now we'll be coming to the LADA. Let's discuss LADA. What is LADA? Latent autoimmune diabetes of adults. Now in that we'll be discussing this is an majority of patient who are with autoimmune related disease. There will be, like in Modi, what was that? Group of inherited genetic disorders, right? And what is there? Majority of patients with autoimmune related disease that is present in younger in life, and however a small group of patients who develop such problems later in life. There will be some group of patients who will be developing this disease, and these patients are often misdiagnosed as type 2 diabetes mellitus. There will be other types also. There is any pathological processes which damage the insulin producing cells of the pancreas. So what is the thing? Diabetes caused due to the damage of the insulin producing cells, right? So whatever the pathological process will be going to damage the insulin producing cells of the pancreas can lead to develop diabetes. Okay, now what is the example of those diseases? Can be possible chronic pancreatitis and hemochromatosis. Okay, so there are some drugs also which can lead to raise the glucose levels, and I'm talking about drugs that is a glucocorticoids, right? That can lead to result in raised blood glucose levels. Okay, so LADA is a disorder in which, despite the presence of islets or antibodies, a diagnosis of diabetes, the progression of autoimmune cell failure is slow. In contrast to diabetes mellitus, 2 patients are typically younger and without an increased body habitus. And in contrast to diabetes mellitus, 1 is not usually required in the early stages of the disease. Okay, now let's talk about the diagnosis. This is the diagnosis, and we'll be discussing what is the aided through that. There will be GAD, glutamic acid decarboxylase, which can help to diagnose it. There will be an autoantibodies test and evidence of other aids. Okay, now let's discuss about the symptoms and signs of diabetes mellitus. So presentation of diabetes mellitus depends very much on the type. So there are 2 types which you know, guys: type 1 diabetes mellitus, type 2 diabetes mellitus. What happened in type 1 diabetes mellitus? You have to remind it, you have to thoroughly repeat it with me so you can learn it now itself. What happened in type 1 diabetes mellitus? There will be weight loss, there will be polydipsia, there will be polyuria. Polydipsia meant to be excessive thirst, like people will be feeling excessive thirst, like excessive need of water they are feeling. Okay, and polyuria, excessive passing of the urine at the time of night. Okay, so this is the thing which we need to remember. Also, type 1 diabetes mellitus may present with diabetic ketoacidosis. And what happened in diabetic ketoacidosis? There will be abdominal pain, there will be vomiting, there could be a reduced consciousness level. So let's repeat together. In type 1 diabetes mellitus, what happened? Weight loss, polydipsia, excessive thirst, polyuria, excessive passing of urine at the time of night, and there will be presence of diabetic ketoacidosis, which meant to be abdominal pain, vomiting, reduced consciousness level. And here you're done with the symptoms and signs of type 1 diabetes mellitus. Now let's discuss about the type 2 diabetes mellitus. This is picked up incidentally. This is picked up incidentally on routine blood test. Okay. When you are going for the routine blood test, this get picked up incidentally. And there will be also polydipsia. There will be polyuria. Remember that the polyuria and polydipsia are due to water being dragged out of the body due to osmotic effects of excess blood glucose being excreted in the urine, that is glycosuria. So what happened, that polyuria and polydipsia happen because of water being dragged out. And why? Due to osmotic effects of excess blood glucose being excreted in the urine, that is glycosuria. Okay, now let's discuss about the investigation, what you can do to investigate this. And yeah, let's discuss about the investigation. There are 4 main ways to check blood glucose. There will be a finger prick bedside glucose monitor. There will be one-off blood glucose. This may be either by fasting or non-fasting, right? And there will be an HbA1c count. Okay, this measures the amount of glycosylated hemoglobin and represents the average blood glucose over the past 2-3 months. So this we have to, this is the thing which we have to remind. HbA1c is the thing where we can by which we can investigate this. And what is this? This is the glycosylated hemoglobin, which can this measures the, what this can measure? This can measure the glycosylated hemoglobin, and this represent the average blood glucose approximate for the past 2 to 3 months. Okay, a glucose tolerance test. What happened, like we learn these things but we don't know exactly what is this, what this is going to measure. That's why I'm repeating it from the basic, so you get to learn each and everything. Okay, a glucose tolerance test. In this test, a fasting blood glucose is taken, after which a 75 glucose load is taken. 75 gram glucose load is taken. After 2 hours, a second blood glucose reading is then taken. So we have to check the glucose tolerance test. The diagnostic criteria are determined by WHO. If the patient is symptomatic, fasting glucose greater than or equal to 7.0 millimole per liter. Random glucose greater than or equal to 11.1 millimole per liter, or after 75 gram oral glucose tolerance test. So this thing you have to remind. If a patient is symptomatic, there will be fasting glucose will be greater than or equal to 7.0 millimole per liter. And we'll be discussing about the random glucose will be greater than or equal to, or I'll do it like that, or equal to 11.1 millimole per liter, or 75 gram glucose tolerance test. Okay, so this is everything is written there. I just want you to remind everything. If patient is asymptomatic, let's discuss this. If patient is asymptomatic, the above criteria apply but must be demonstrated on 2 separate occasions. Okay, this need to done by the 2 times. Okay, in 2011, WHO released supplementary guidance on the use of HbA1c for the diagnosis of diabetes. Now we have to learn about the diabetes mellitus HbA1c count. Okay, so let's discuss. HbA1c of greater than or equal to 6.5%, that is 48 millimole per liter, is a diagnostic of diabetes mellitus. What I am telling you is, in diabetes mellitus, there will be HbA1c count should be greater than or equal to 6.5%, that is 48 millimole per mole. Okay, so this is the diagnostic of diabetes mellitus. Now, if HbA1c is less than 6.5, does not exclude diabetes, it's not exclude diabetes, that is, it is not as sensitive as fasting samples for detecting diabetes. Like if it is less than that, it is not excluding that you are not having diabetes or you are not going to have a diabetes, but it's like you're not having that sort of sensitive fasting samples for detecting diabetes. A patient without symptoms, the test must be repeated to confirm the diagnosis. It should be remembered that misleading HbA1c results can be caused by increased red cell turnover. Okay, so fasting glucose is less than equal to 6.0 millimole and that is a greater than 7.0 millimole. Now let me tell you, normal glycemic control. There will be a pre-diabetes where HbA1c is 42 to 47 millimole. That is, could be less than 6 millimole. Right, we know what is the exact criteria. That is equal to 6.5, 48 millimole. Right, greater than equal to 6.5. And if it is less than 6, that would be having the chances of the pre-diabetes. Correct? And fasting glucose would be 6.1 to 6.9, somehow like that. And if it is greater than 7.0 millimole, that is the diabetes mellitus. Exact. If it is greater than that, that is a diabetes mellitus. But greater than 6.5 is a diagnostic threshold for the diabetes. Less than 41 millimole or 5.9, if it is, that will be equal to this or below are considered normal. If it is less than, guys, what I am telling you, if it is less than or equal to 41 millimole per mole, that is equal to considered as normal. Okay, this now diagram showing the spectrum of diabetes diagnosis, as I told you, right? If it is, like, let me tell you in a very simple manner, if it is greater than or equal to 6.5 HbA1c count, that is 48 millimole, it is the diagnostic of diabetes mellitus. If it is greater than 7.0 millimole, that is the exact diabetes mellitus. If it is less than 6.0 millimole, that could be 40 to 47 millimole, that could be a pre-diabetes. And if it is less than 5.9 or 41 millimole, that is considered to be normal, right? So here we are completed with the investigation. Now we'll be learning about the management. The principle of managing diabetes mellitus are as follows. Drug therapy. Okay, there will be a drug therapy to normalize blood glucose level. There will be monitoring for and treating any complication related to diabetes. There will be modifying any other risk factors for other conditions such as cardiovascular disease, right? So what I am telling you is drug therapy, monitoring and modifying any other risk factors of other conditions such as a person would be having a cardiovascular disease or other. Okay, now type 1 diabetes always require, like a patient who come with the type 1 diabetes always require insulin to control the blood sugar level. This is because there is an absolute deficiency of insulin. with no pancreatic tissue left to stimulate with drugs. So what happened in type 1 diabetes mellitus? Let me tell you in a very simple manner. In this, it's required that you have to give the insulin to control the blood glucose, blood sugar levels, because there is an absolute deficiency of insulin. Okay, there is no pancreatic tissue left which can stimulate with drugs and you can treat it. Okay, different types of insulin are available according to their duration of action. Now let's come with type 2 diabetes. The majority of patients with type 2 diabetes are controlled using oral medications. Okay, so first line drug for the vast majority is metformin. Write it down or remind it. Okay, so first line drug for the type 2 diabetes mellitus is metformin. Second line drugs include sulfonylureas, gliptins and pioglitazone, and we'll be discussing everything related to this afterwards, but it's a very short and sweet manner. You have to learn this. Okay, now if oral medication is not controlling the blood glucose to a sufficient degree, then only you have to use the insulin. So let's discuss type 1 diabetes require insulin and how. Type 2 diabetes mellitus could be treated with the first line drug, that is metformin, reminded guys, and second line drugs sulfonylurea, gliptins and pioglitazone. And if these oral medications can't be able to control, the insulin is used. Okay, correct? Now this is the table below given, main drugs used in the management of diabetes mellitus. You can go through it by yourself also, or I'll just read it out for you, so you will complete it with me itself. Right, insulin, direct replacement for endogenous insulin, that is having a route which is subcutaneous, and that is having some side effects that could lead to hypoglycemia, weight gain and lipodystrophy. Okay, that can lead to hypoglycemia, weight gain and lipodystrophy, used in all patients with type 1 diabetes mellitus. Correct? And some patients with poorly controlled type 2 diabetes mellitus can be classified according to source, analog, human sequence and porcine, and duration of action, short, immediate, long acting. So these have to be classified according to the source of the patient, like how much and what kind of diabetes they are having, like it is more than, or like it is severe or no, to be normal, somehow like that we have to discuss. And type 1 diabetes mellitus is really needed the insulin only. If poorly controlled type 2 diabetes mellitus, there will be a need of insulin. Okay, route is subcutaneous, but there are some side effects, hypoglycemia, weight gain and lipodystrophy. Correct? You are done with this. Now let's come to the metformin. This will increase the insulin sensitivity, increases insulin sensitivity and decreases hepatic gluconeogenesis. What this will do, metformin increase insulin sensitivity and decrease hepatic gluconeogenesis. So the root of this is oral, right? There are some side effects, that is gastrointestinal upset, GI upset and lactic acidosis. You can see there is a star marking, right? Lactic acidosis. Okay, so first line medication in management of type 2 diabetes mellitus, I told you, first line cannot be used in a patients with eGFR of less than 30 milli per minute, can't be used. Okay, sulfonylureas stimulate pancreatic beta cells to secrete insulin. So what it will do, it will stimulate the pancreatic beta cells, which can help to secrete insulin. So this is also having a route which is oral. Side effect is weight gain. Okay, hypoglycemia, hyponatremia. Examples including gliclazide and glimepiride. There is thiazolidinediones. Okay, so activate PPAR gamma receptor in adipocytes to promote adipogenesis and fatty acid uptake. The route is oral, and this will also do weight gain and fluid retention. Only currently available is pioglitazone, thiazolidinedione. So now what is available is pioglitazone. Now let's come to the DPP4 inhibitors, that is gliptins. What it will do, it will increase the incretin levels which inhibit glucagon secretion. That is also having an oral route. Okay, generally well tolerated, but increased risk of pancreatitis. Increased risk of pancreatitis. Which is that DPP4 inhibitors. You have to remind it everything. Okay, just read it out thoroughly with me, guys. Okay, be active. Let's discuss SGLT2 inhibitors, that is gliflozins. And what it will do, it will inhibit reabsorption of glucose in the kidney. DPP4, what it will be do, it will increase the incretin levels, that will inhibit the glucagon secretion. And SGLT2, what it will do, inhibit the reabsorption of glucose in the kidney. Route is oral only, and the side effects is urinary tract infection, typically result in weight loss. Okay, typically result in weight loss. Now let's discuss about the GLP-1 agonist, that is TIDES. SGLT2, gliflozins, and DPP4, gliptins. Thiazolidinediones, which is only available is pioglitazone. Sulfonylurea can be having example like gliclazide and glimepiride. Correct. There is metformin and there is insulin. There is what happens, GLP-1 agonist, what it do, incretin mimetic, which inhibits glucagon secretion. That is having the route which is subcutaneous. Insulin is having a subcutaneous route. This is also having a subcutaneous route. What it will do, it will do nausea and vomiting, also pancreatitis. Also DPP4 also leads to increased risk of pancreatitis, right? And this is also typically result in weight loss. Okay, now this is nice, provides the guidelines on how drug therapy should be used in T2DM. Okay guys, so everything given in this chart you can just go through with this also. This is the nice provide guidelines how drug therapy should be used in T2DM. There is a metformin given, you can just see it, go through with this. Okay, and I already told you the management related to the type 1 diabetes mellitus and the type 2 diabetes mellitus. We already discussed the pathophysiology. We already discussed the basic introduction related to the type 2 diabetes mellitus. So this is all about this lecture. I hope you really like this lecture. I tried to cover everything in a very simple manner. I hope you will definitely share it with your friends and your colleagues too, so this will help me to also grow this YouTube channel, and you will also help your colleagues to get that information. And for your info, I have a Telegram channel also which is having this name Study Smart with me. You can just come and follow me over there, connect with me over there, because at there I used to share the questions. Also there are a lot of materials I'm providing, so I'll provide the link in the description below. Also you can just search it with that name too, and having an Instagram channel also with this name itself. So we'll be coming with a lot of videos related to this kind of lectures. And thanks for watching me, and have a very good and nice day. Thank you.